Hi everyone, if you want to know all about urine drug screening and also how some people think they can beat a urine drug screen, stay tuned. Okay, so we're going to do this deep dive into urine drug screening. I've been asked many times by many people about the ins and outs. So here we go. So urine drug screens in Australia are determined and regulated by specific guidelines, and in particular the Australia-New Zealand guidelines 4308/2008, which is the standard for urine drug testing, and also ASNZS 4760/2019 for oral fluid testing, i.e. saliva. So a lot of what I say will be based on those guidelines. So first of all, the biological substrates. What can you actually test if you're going to test for a drug? And really the primary substance is urine. And this has got several advantages. So it's non-invasive, it's relatively easy to collect. And there are higher concentrations of drug metabolites in urine compared to blood or saliva. And for most substances, there's also a longer detection window. And we'll get to detection windows in a moment. But just to bear in mind that there are other body substrates that can actually be used for drug testing, and that includes oral fluid, saliva, that includes hair, blood, sweat, and even in some forensic contexts, nail clippings. So the bottom line is it's very difficult to avoid having to give some form of body tissue for drug testing. Okay, so let's talk about detection windows for common drugs in urine. This is a subject upon which there's been much discussion, and I have been asked frequently about it, in particular by people who want to know how to beat a urine drug screen. Detection windows are very approximate and are based on metabolism, dose of drug ingested, the frequency of use, the level of hydration, i.e. whether or not you're dehydrated, and also the sensitivity of the test. So what I'm going to say next is just a rough guide and is just average. For short-term cannabis use, you have a detection window of between 3 and 7 days, and that's for occasional users. If you are using cannabis for prolonged periods of time and at heavy high doses, you push that level up to 30 plus days. Right? And the reason for that is because cannabis is very lipophilic, it's absorbed in fat, and it therefore is stored in fat stores in the body. And so when you stop using, there's a large amount of THC hanging about your fat stores, which is slowly released back into urine. Cocaine is 2 to 4 days. Opiates, including morphine, heroin, and codeine, 2 to 3 days. Methadone, 3 to 5 days. Benzodiazepines, 3 to 7 days short acting, but again, long acting drugs like diazepam the time windows can be up to 4 weeks or more. Amphetamines, including methamphetamine, 2 to 4 days. MDMA, ecstasy, 2 to 4 days. Synthetic cannabinoids, e.g. spice, that's very variable, and the time windows can be hours to several days. And also alcohol metabolites such as ethyl glucuronide or ETG, the detection time window is up to 80 hours, which is about, three and a bit days. So those are the detection time windows for common drugs. Most of them are around about the 3 to 4 day mark. But for fat-soluble drugs such as cannabis and for long-acting drugs such as diazepam, the time window can be over 4 weeks. Okay, so let's look at screening versus confirmatory testing. So most urine drug screens done in Australia are just screening tests. These are the initial tests and use antibodies to detect classes of drugs. So rather than detecting a particular opiate, for instance, rather than detecting morphine or codeine, it will detect opiates. It will detect benzodiazepines, it will detect amphetamines, but it will not detect the specific drug in that class of substances. So it's basically a test for the presence of any member of a family of drugs. Nonetheless, it is used widely because it's rapid, it's cost effective, and it can be done at point of care. So you can actually have urine pots attached to which are the specific testing reagent strips. So you can actually get a test result there and then at the point of testing, and that's called point of care testing. Now, because urine drug screens are antibody screens of class, they are associated with false positives and false negatives. So a false positive occurs due to cross-reactivity. A false positive means that you haven't actually taken the drug, but the test shows up positive. And a false negative means that you have taken the drug, but the test is negative. And false negatives are quite common, especially if you're ingesting synthetic drugs or weakly reactive substances. The next level of testing is GCMS or LCMS, and these tests are the gold standard confirmatory tests. And so GCMS stands for gas chromatography mass spectrometry, and LCMS stands for liquid chromatography mass spectrometry. And these tests identify specific molecules, i.e. specific drugs, with high precision, and they're also able to quantify drug levels. And so these are second-line tests that are used to confirm positive screening results. And because they're so accurate and because they're able to give you quantities, then they form part of forensic and medical legal proceedings. We said that GCMS, LCMS can give you a quantity, not only just whether or not it's present, but also a quantity. There are specific legally defined cutoff levels in Australia according to ASNZS 4308, 2008. Remember, I mentioned that guideline. And so for cannabis, the screening cutoff in micrograms per litre is 50, but the confirmatory cutoff is in micrograms per litre is 15. So here we're seeing a much lower threshold cutoff because the GCMS, LCMS test is so much more accurate. And the particular substance that we're looking for in urine to test for THC cannabis is THC carboxyl, so carboxyl THC. Now we'll move to cocaine. So the metabolite we're testing in urine is benzyl agonine, and in the screening tests, we're looking at a cutoff of 300 micrograms per litre. But in the confirmatory test, we're looking at a cutoff of 150 micrograms per litre. For opiates, we're looking at, in particular, morphine or 6-acetyl monomorphine. And the cutoff is 300 in the screening test, and in the confirmatory test, the cutoff is 150 micrograms per litre. For amphetamines, we're looking for amphetamine or methamphetamine, and the screening cutoff is 300 micrograms per litre, and the confirmatory cutoff is 150 micrograms per litre. For benzodiazepines, in particular oxazepam and temazepam, we're looking at 200 micrograms per litre as the screening and 100 micrograms per litre as the cutoff. So in every situation, we have a substance that we're analyzing, and the cutoff for the screening test is much higher than the cutoff for the confirmatory test. And so the confirmatory test is used to confirm what is known as the non-negativity of the screening test. Now, I've said to you that the screening test is a test of class and tends not to also show positive for synthetic drugs. So drugs that are not detected on standard panels include the following. So synthetic opioids, in particular tramadol, fentanyl, buprenorphine, these don't show positive on a standard opiate screen. And so you can get urine drug screens that are specifically designed to show positive for these substances, but you have to request them. But then also oxycodone, endone. Endone has got low cross-reactivity with opiates, morphine in a urine drug screen. And so unless you're using very high doses of endone, you probably will not show positive for endone. And then if we're looking at tests of class for benzodiazepines, so specific benzodiazepines that tend not to show up in a first-line urine drug screen include clonazepam, alprazolam, and again, Z drugs. Z drugs are synthetic drugs that are like benzodiazepines, but because they're synthetic, again, they're not really going to show positive. So zolpidem, or otherwise known as Stilnox, is missed on standard panels. And then drugs of misuse, such as LSD, GHB, and ketamine, these are not detected in urine drug screens, on routine urine drug screens. And so if you're concerned about specific drug use, then you need to go for GCMS, LCMS testing. And then we need to also understand the errors associated with tests of antibody, or antibody tests of class rather. So if you're looking for cannabis, you're going to be testing for THC. You can get false positives with ibuprofen and pantoprazole. So even if you're not taking cannabis, if you're taking pantoprazole for your stomach or ibuprofen for your joints, you could show positive for cannabis in a routine urine drug screen. If we move to opiates, then if you're taking the antibiotic rifampicin, that can show positive for opioids. And also if you're eating bread with poppy seeds on it, that can show positive for opiates. When we're testing for amphetamines, if you're taking nasal decongestants like pseudoephedrine, that will show positive. If you're taking the smoking cessation drug bupropion, that'll show positive. If you're taking the stomach acid pill ranitidine, that will show positive. And if we look at benzodiazepines, the antidepressant sertraline may make you show positive for benzodiazepines. And for phencyclidine, PCP, if you're taking diphenhydramine, the sedative antihistamine, that will make you show positive for PCP. And it's also possible to show positive for cocaine, although it's rare, if you're using topical anesthetics such as Novocaine. Now, causes of false negatives. So you can show negative even though you've taken the drug. And this is of specific interest to certain individuals. But false negatives can occur with dilution of urine via fluid overload, so drinking a lot of water. It can occur because of drug use outside the detection windows. It can occur because of drug use not covered by the panel, so the use of synthetic drugs. It can occur because of rapid metabolism or altered excretion of the drug. And it can occur because, quite frankly, you've just submitted synthetic urine or someone else's urine. So there's a breakdown in the chain of custody, which we'll talk about next. So if we're thinking about adulteration and evasion techniques, people may attempt to beat a urine drug screen using the following. So you can think about chemical or physical adulteration. So thinking about the use of bleach or soap or vinegar. This alters the pH of the urine, and you can detect that by looking for tests of oxidation or visually inspecting the urine. You can use synthetic urine, so you can actually buy a substance that looks like urine, and you can test for that by checking the temperature and also testing for a substance in urine called creatinine. You can also use Visine, or at least there's an urban myth that you can use eye drops such as Visine. That doesn't really work. And any kind of substitution, any kind of urine substitution, the key thing is temperature. So if the sample has got a temperature outside the range of 32 to 38 degrees, then it's not really compatible with physiological excretion of urine. Another way of doing it is by dilution. So you can have a large volume of water to drink, which then reduces the concentration of the drug in your urine below the cutoff for detection. But remember, if you're going to dilute urine by adding water to the sample, then that will reduce your creatinine or the specific gravity. So the minimum level of creatinine in urine, in physiologically produced urine, is 2 millimoles per liter. And the minimum specific gravity is 1.003. So if your urine is too dilute, it's going to be detected. Now, I want to talk to you now about bicarbonate and the manipulation of urinary pH specifically. So a lot of people will use bicarbonate to reduce the excretion of drugs like methamphetamine, MDMA, and sometimes PCP. So bicarbonate ingestion will make the urine more alkaline. Alkalinization of the urine will actually increase the reabsorption of amphetamines from the urine back into the kidneys, and therefore delays urinary excretion. And this may result in a false negative if you've timed it well. But again, if the pH of your urine is more than 8, so if it's more alkaline than 8, again, that's a warning sign. But you also have to understand there are significant health risks associated with the ingestion of bicarbonate. So, from a medical point of view, I'm not recommending that anyone tries to adulterate urine, and certainly I'm not recommending that anyone takes bicarbonate to do so. Other related interventions include, instead of using bicarbonate, you can use vitamin C or cranberry juice or potassium citrate. And these all have the effect of increasing the pH, alkalinization of the urine. And then lastly, you can use diuretics to promote dilution. Again, you produce a very, very dilute urine, and hopefully the urine, any drugs in the urine are below the detection thresholds. But again, this is very risky and potentially has health effects. So just be careful about the health effects around trying to adulterate urine, and in particular, bicarbonate loading increases the risk of metabolic alkalosis, hypertension, high blood pressure, and fluid overload and electrolyte imbalance, which quite frankly, unfortunately, can lead to death. Now, we also need to understand individual patient factors that influence a urine drug screen. So urine drug screen results can vary depending on patient physiology and metabolic rates. So if we look specifically at metabolism, fast metabolizers will metabolize drugs more quickly and excrete drugs more quickly. Having a large body fat content, having a high BMI, also affects the excretion of fat-soluble drugs such as cannabis. And so high body fat prolongs the detection window. And then levels of hydration affect concentration of urine and also concentration of drug levels. And so too do liver and kidney disease. So if you've got impaired clearance, if you're not able to clear the drugs, then you've got a longer detection window because more of the drug hangs about in your own system. Age. So the elderly have a slower metabolism, again, prolonging the drug detection windows. And then frequency of use. So chronic use leads to drug accumulation and longer time windows for detection. So we need to then talk about, how do you actually produce a urine sample? The collection of urine according to forensic and medical legal standards is determined again, as I've said, by AS/NZS 4308. And under this guideline, observed urine collection is permitted and sometimes required, particularly in forensic settings, workplace misconduct cases, and addiction treatment compliance monitoring. So the procedure involves the collector witnessing the donor pass urine directly from the body into the collection cup. This is informally referred to as the meatus to the cup rule. So the hole from which urine leaves the body is called the meatus. So this means that the direct observation of urine exiting the body from the meatus into the cup reduces the risk of tampering. However, it also means that the collector will be visualizing a man's penis and visualizing a woman's genitals, which can be confronting. But people need to be aware that if you're doing a urine collection and it's directly observed, according to the guidelines, you are effectively exposing your genitals to the view of the urine collector, and that is according to the guidelines. So just to emphasize that direct observation of the genital area in women is actually required under these guidelines. Nonetheless, the collection of urine tests is actually the subject of specific training, and collectors do have to undergo training accreditation, and they have to comply with professional standards and maintain privacy and dignity according to the guidelines. So there we have it. That's urine drug screening. Hopefully this has answered all of the questions that I've been asked, both online and in person. If there's anything you'd like to know more, then contact us and we'll do another session on it. But for now, that's all for today, folks. My name's Dr. Fergal Armstrong, and this has been Cracking Addiction.